Some of the most anticipated and consequential rules relate to the Medicare Shared Savings Program. Now, if you're not in the Medicare Shared Savings Program, you don't anticipate to be there anytime soon, you can skip this section and go on to my other sections. I've divided this discussion into the Medicare Shared Savings Program, alternative payment models, MIPS, that is the merit-based incentive payment system, and MIPS value pathways, that is MVPs. So first, back to the MSSP. Let's talk about quality measurement. MSSP ACOs are required to measure the quality of their care, submit quality measurements to Medicare, and meet minimum quality standards in order to qualify to collect a share of healthcare savings they may have generated. Now, this final rule confirms what we've anticipated for several years now, that the web interface mechanism of measuring and submitting quality will end after 2024 measurements are completed in submission. This is not so much a measurement as a sampling technique predominantly done with manual chart abstractions. It's been the predominant method of quality measurement by ACOs since 2013, when ACOs were introduced by Medicare as a health care delivery and payment method. When the web interface sunsets after 2024 measurements and submissions, ACOs will have to use one of three mechanisms to measure and submit quality of care data. One option is the electronic clinical quality measures, that's ECQM's mechanism. Another is the new Medicare clinical quality measures mechanism, or for 2 more years, that is 2025 and 2026, the MIPS CQM's clinical quality measures mechanism. Yes, MIPS clinical quality measures, that is MIPS CQMs, are preserved for ACO use for 2 more years. Now, as for Medicare CQMs, they have performance period benchmarks for the first year in 2024, but this rule finalized flat benchmarks for the 2025 for the core APP set of measures using Medicare CQMs. Flat benchmarks for the first 2 years as each new measure is introduced into the APP Plus measure set. Now, this rule finalizes a new set of measures applicable to the MSSP and to other APMs. Based on the APM performance pathway, that is the APP, Medicare just finalized a new APP Plus measure set, which includes additional measures that will phase in over the next few years. For 2025, in addition to hemoglobin A1C, depression screening, and blood pressure control, APP Plus is requiring the breast cancer screening measure that we've been familiar with from years past. Same measure, no longer available for use in MIPS, in traditional MIPS, but available here for use for MSSP ACOs and other APMs. Now, for 2026, APP Plus will include colon cancer screening. For 2027, treatment of substance use disorder, that call it initiation and engagement. For 2028, the last 2 measures, screening for social drivers of health and adult immunization, will click in. Now, those last 3 measures, substance use disorder, social drivers of health, and adult immunization, are not currently supported by ECQM specifications, and Medicare intends to postpone those if the specifications are not yet ready and published. The APP Plus measure set aligns MSSP quality measurement with 10 adult universal foundation measures that is also the basis for Medicaid core sets, for marketplace quality rating system, for value in primary care MVP, and also is converging with Medicare Advantage quality measurement and Part D star rating. Expect all of these measure sets from now on to remain coordinated through what Medicare is calling that universal foundation measures. They've put an infrastructure in place to support that universal foundation measure set. There's a set for adults, a set for children. Of course, for these programs, for this the MSSP program and other APMs in Medicare, it's only using the adult measure sets. Now, the original APP measure set is still available for use by MIPS APM entities other than the MSSP. MIPS APM entities can also choose to submit the APP Plus measure set. MSSP organizations must use the APP Plus measure set. It is intended from now on to be the standard for MSSPs to qualify to collect their shared savings. Now, neither the APP nor APP Plus is available to any traditional MIPS providers or practices. Now, moving on, there is a new complex organization adjustment. It's to incentivize ECQM submission. It applies to complex organizations like HCOs and APM entities, and it also applies to virtual groups submitting traditional MIPS. The bonus is one achievement point for each ECQM submitted by one of these organizations. It must meet case minimums and data completeness criteria. It's capped. You can't go above 10 measure achievement points for each measure. So if you get a perfect score for a measure, you can't also collect that complex organization adjustment. And of course, you're capped at 100% for the quality category. Notice it applies not only to the ACO and other APMs, but also to virtual groups and traditional MIPS. Now, there's also an alternative quality standard we've seen in the last few years when the APP measures were submittable by web interface or by ECQMs, MIPS CQMs, or for this 2024 year, Medicare CQMs. Those who used the APP CQM measures early were given an alternative quality standard. Usually, the current standard is that your composite score on quality needs to be at the 40th percentile or above. But for users of ECQMs or MIPS CQMs, they were given an alternative standard that means that one outcome measure has to be at least at the 10th percentile, and one other measure, could be an outcomes, could be any of the measures, has to be at or above the 40th percentile. So it's a lot easier to hit, and as measures become more numerous in APP Plus, it's even a bigger advantage to use one of these methods. Now it applies to anyone. They've extended it now as long as it would appear, as long as Medicare CQMs are permissible, anyone who uses an all patient, all payer method like ECQMs or MIPS CQMs will get the alternative quality standard. So again, a lot easier to collect your shared savings. Now, we've seen a health equity benchmark adjustment introduced in the past. Its design was tested and refined in the REACH program. It's now being used as a third method to upwardly adjust historical benchmarks for MSSP ACOs and applies to agreement periods beginning on or after January 1st, 2024. So if you're a new or renewing ACO anytime after January 1, 2024, the health equity benchmark will apply to your historical benchmarks. Now, promoting interoperability is an interesting topic for MSSPs. Now, there's no new rules pertaining to MSSPs and promoting interoperability in the 2025 final rule, but one of the most consequential rule changes for MSSPs was finalized in the 2024 final rule, but scheduled to take effect for 2025, starting January 1st, 2025. So starting then, all participants in MSSP ACOs, and indeed any alternative payment model, is now required to use CERT. No longer is there a 75% or a smaller 50%, in some cases, goal of certified EHR use. And all those participants must also make a promoting interoperability submission. Now, there's one big, if understated, exception. Providers who have a temporary or permanent exception to the CEHRT requirement get the same exception for participation in MSSP. Small practices, non-patient facing practices, hospital-based or ambulatory surgical center-based practices have a pass for in MIPS for promoting operability, they do as well for in MSSPs. Although, warning, that's contradicted somewhat by the rule that, or the intention to head to solely ECQMs in the near future. So it may be an empty promise of Medicare to accept those from the rules. Now, an interesting side note on this promoting interoperability requirement pertains to facility-based providers. Medicare offers an exception to promoting interoperability requirements for providers who are facility-based and therefore have no control over the EHR in use at the facility. This is important. Those providers didn't and can't have a say in which EHR is used, but they also don't have any power to insist on data being delivered to them. And I think that's what, in practical experience, what we find limits use of those. But the only automatic grants of the exception occurs for hospital-based and ambulatory surgical center-based providers. And for them, it only applies automatically if one of the facilities in which they work accounts for at least 75% of their billing volume. Providers in other facilities like skilled care and other long-term care facilities, or providers who serve multiple facilities with no one of them rising to at least 75% of their volume, don't automatically get that exception. Those providers must make an EUC application. That is an exceptional and unusual circumstances application to be granted the exception. Of course, that EUC application needs to be repeated each year if it still applies. And I'm finding in our clients that make that application that it's ratified, it's verified fairly quickly by Medicare. But again, don't expect it to be automatic if you're not in one of those specific facilities or have at least 75% of your volume in one. Another important change in the rules is a prepaid shared savings option. Now, you may remember in 2024, Medicare introduced an advanced investment program called the AIP that is available for new low revenue MSSP ACOs. The program seems to be popular, it seems to be successful, and for 2025, Medicare finalized a rule to make advance payments of anticipated shared savings available to select renewing ACOs. Now, there's a number of qualifying prerequisites regarding prior year performance, but it may be a very useful tool. Now, it's only available at the time of renewal, but early renewal is permitted to qualify for this option. If the first year of a new renewal is 2025, you're eligible for this in 2026 without an early renewal. Now, as for the advanced investment program, a couple of refinements. Voluntary termination with payback has become acceptable without leaving the MSSP. That was an unintended consequence of the rules as written last year, and that's been corrected. And they've also clarified that if Medicare involuntarily terminates an ACO's participation, that payback of any AIP funds is required. And payback in either case is expected within 90 days of the event. Now, a few adjustments to financial methodology for MSSP ACOs, a number of refinements. There's a mechanism to remove from benchmarks and performance year calculations service codes that exhibit, by analysis, significant, anomalous, and highly suspect, that's abbreviated SAHS billing activity. So they will tend to remove those codes both from the benchmark years codes and the billing years codes to just eliminate those from the shared savings or shared loss calculations. They've also provided some clarity on methodology for capping the ACO's risk score growth and regional risk score growth. They've provided some more clarity around the health equity benchmark adjustment. And they've clarified and refined the rules for reopening payment determinations under various circumstances. Now, there's also some changes about the expectation to have 5,000 beneficiaries. In the past, if an ACO dropped below 5,000 beneficiaries, they were put on in a provisional status, required to develop a cap, that is a corrective action plan. But what they've found is that most of these do correct. That they've instituted a sliding scale for minimum savings rates. That's MSR, and minimal loss rates. That's MLR. And that's been effective to prevent anomalous losses or gains. So they're not taking the drop below 5,000 as seriously as they did. Current rules now say that you have to have 5,000 beneficiaries at the start of your ACO or at renewal time, but interim drops no longer require an automatic corrective action plan. Now, they typically tweak assignment methodology in most final rules. This year's no exception, with a couple of interesting tweaks. First, they're making an exception to voluntary assignment for patients who are eligible for a disease and condition specific APM model under study by the Center for Medicare and Medicaid Innovation. They point out that voluntary assignment is a rare event. Out of 10 million Medicare beneficiaries in the MSSP program, only 83,000 of them in the last measured year voluntarily assigned, and they think it's important to fully study these disease and condition specific APM models to put those to allow those patients to be attributed to those models so they can be fully studied. The other change to the assignment methodology relates to the step related assignment methods. Step one is based on primary care services by primary care providers. Step two is based on primary care services by second tier specialists, which can serve in a primary care capacity. And step three is the new step. It involves a 2-year look back for someone who was seen by a primary care physician 2 years ago, and again by non-physician primary care provider in the current year. So this should result in more patients being attributed to each ACO. Now, and amongst the smaller things happening, there's been relaxation of antitrust concerns based on withdrawal by the Department of Justice and the Federal Trade Commission of some of their outdated policies on antitrust. So there's not going to be an automatic review anymore of ACO applications. They will handle those on case-by-case basis if there's any special reason for concern. And they've also relaxed some beneficiary notification requirements. And that, I think, is just about it for the MSSP related rules, or at least the high-level rules, and a brief review of those. We will dive into some of those in greater detail in future days and weeks. And of course, if there's something you want us to dive more deeply into, please just let us know what that is.